heart and lung content. If you like that, you're going to love this. Okay. So this is going to be a talk on post-amputation pain syndromes. I'm Gerasimos Bastas. I'm a physical medicine rehab specialist over at Vanderbilt, where I serve as the director for limb loss rehabilitation. And yeah, I'm excited to talk to you about this content today. All right, I'm going to slowly get started here. I have no disclosures related to this activity. And I think one of the most important things that we need to do in terms of like reviewing the literature and educating our patients, right, is to actually have like a common language with them, right? It's not unusual, right? People will come in and will say, hey, do you have pain? They're like, yeah, I got pain. And it's like, we just leave it at that. Let's not, right? And it's a lot of the times, our framing matters, right? So we'll tell patients like, do you have phantom? They're like, yeah, I got that phantom pain. It's like, wait a second. What do you mean, right? They're like, are these sensations? Are this pain? So it's good to develop a language with them, a common language, so that they know what we mean and they communicate faithfully back to us what they're experiencing, right? So we can figure out what needs doing. All right, so obviously, right, three big buckets that we talk about: residual limb pain, right, or stump pain. Happy to call it a stump if they're okay with it, right? So residual limb pain. So which then we're talking about pain in the actual remaining part of the amputated limb, right? Documented as a residuum, right? And but here's the kicker, right? So this pain in the residual limb, it may include focally induced nociceptive pain. So this is pain, right? Like muscle and bone pain, so to speak, right? That's how we wrap our mind around it, right? So this is pain elicited by damage to structures, anatomical structures within the residual limb, right? But it can have neuropathic qualities to it, right? Dysesthesias, allodynia. So here's what these mean. So when we talk about, let's say, paresthesias, right? We talk about an abnormal sensation to the skin, right? Where there's no sign of skin damage. You look at it, there's no discoloration, there's no wounds or anything, but people are reporting, different sensations like formication, like little ants, creepy crawlies, this, that, the other. This part feels cold, a little bit stinging, burning, whatever. You can't see it. Dysesthesias, right, are a little bit different. So dysesthesias are definitely an abnormal sensation. It's unpleasant sensation. It can have a lot of the same qualities, right? Stinging, burning, etc. Typically, though, caused by nerve damage. Okay, so and it can declare itself in the residual limb itself or further down in the phantom. So dysesthesias kind of span the spectrum, but typically consequent to nerve damage itself. Okay, so allodynia, which we'll talk about a little bit, is things that shouldn't elicit pain out of proportion, right? So very light touch to the residual limb is excruciating, right? These are the folks that tell us, hey, I can't even put the bed sheet on it, right? That's allodynia, right? Things that you should be able to tolerate, hot, cold, to a certain extent on the skin, they're intolerant of that. They're intolerant of pressure. So it's good to know about the different qualities, right? And for them to let us know, are all these sort of manifestations just in the residual limb itself, or to the extent of the phantom limb? Now, so here's what's going to happen, right? So when we talk to them, when we talk to them about phantom limb sensations, it's good to qualify for them, right? So these can be paresthesias, dysesthesias, but here's the thing: they're non-debilitating. It's like, can you tune it out? Like, could you carry on? Is it limiting you from using your prosthesis? Like, no. Okay, great. Could you carry on a conversation? Can you tune it out? Yeah, great. Not phantom sensations versus phantom pain, right? So it's good to qualify for people. It's that, oh my God, somebody's like stabbing my ankle with a steak knife, or like my foot's on fire, my foot's in a vise, and it really feels like, it's very distressing, right? So the point here is that again, similar type of neuropathic sensations, paresthesias, dysesthesias, but they're very distressing and functionally debilitating and limiting. I'm like, if it's taking you right out of that moment, it's making you sit it out, it's making you want to take your prosthesis off, that's phantom pain, okay? It's easy to conflate the two, right? So because people have heard of phantom pain, so they'll typically report sensations to us as pains. When I typically try to tease this apart with people, I'll frame it. I'm like, hey, are you having phantom sensations versus phantom pain? Let me tell you how they're different, right? And then people are like, no, no, it's sensations. Like, okay, good. We get excited on the medical side, we get excited about the phantom limb pain, right? Because we want to figure out what all else needs doing, okay? So really important, right? Really important when it comes to this, right? Because again, very distressing, right? Okay, so what do you do when your patients, right, are telling you it's like, my stump hurts, right? It's like, or I'm having, distressing phantom pain, etc. You want to know how to take a pain history. This is very, very important, right? Um, so it helps you guide down to what might actually be happening, right? So a lot of the times you want to elicit some of this information. You're like, it's out of the scope of my practice, my purview. Like, what am I going to do with this information? It's like, no, you got to know. It's very important to keep track of this, right? Because there are some things, right? Like, it's almost like bells should be going off. Like, if this is a prosthetic issue, can be dealt with prosthetically versus adjustments, refitting, etc., is in vain because something else is going on, right? So teasing that apart, it's like, hey, rope us in, right? Tag us in. We'll help you with all this, right? But it's good to know how to elicit some of this information and what to make of it. So, okay, residual limb hurts. It's like, okay, where does it hurt, right? Is this focal or is it global? It's a diffuse pain, right? How intense is this? You're like, is it a 2 out of 10 versus like an 8 out of 10? Big difference, right? So chronicity, is this constant, right? Is it episodic? Does it come and go, right? It only comes when, right? So was this acute onset? Has this been kind of like aching them all along and now it's getting worse, right? So all of these things speak to a process that's evolving, right? And what does it feel like? Do take the time to ask them. It's like they have to reach for the word. Some people will straight out tell you it's sharp, right? Some people say it's just stinging, it's burning, and offer up some of these qualifiers, right? And sure enough, there's probably going to be multiple qualifiers, or at different times it may feel differently. It's like, yeah, okay, document that, okay? Or at least kind of register it, right? All right, let's see. And so ask them, okay, so what brings it on? What happened? Was it a trauma? Was it an accident? Did it happen last Sunday? What were you doing at the time? And what makes it worse, right? So is it socket wear time? Is it active socket use time, like when you're standing and walking, for instance, right? All right, so so let's say, and people may qualify for you, for instance, like, no, it's fine if I'm, it's only when I'm jogging that it gets like, you're like, okay, maybe it's active hyperemia, you're getting the muscles gorging, they're in a confined space, and people just basically, they get tanked with pressures inside the socket, right? So it's a very different thing. And you're like, then pain that's there at rest, right? So you got to figure out what triggers this, what brings it on, what makes it worse, and obviously, what makes it better, right? Okay, it's better when I don't put on my prosthetic supplies. It's better when I take the socket off. It's better when actually it feels better after I've started walking on it. It's like, okay, different things, right? So, and this is the thing, when you're taking a pain history, you're like, they're reporting to you, I've got pain, it's 5 out of 10. It's like, yeah, but I also see that you're on a boatload of like opiate medications and gabapentin and this and that. So what else are we masking, right? You're reporting to us, but in relation to medications you may be taking, other substances, a lot of our patients self-medicate, right? And like, at least in the physician's office, they'll be very upfront with it. Like I've had good experience with people saying, no, I use cannabis, I use this, I use that. It's like, we need to know in the context of what else is going on. Modalities, right? So heat, cold, oh, I put some heat on it, it feels better, or I use cold, or I use these creams, or anything, right? And especially, how does it relate to use of their prosthesis and prosthetic supplies, right? So this is sort of the exercise we go through, right? So when I'm taking like a history like this, somebody's saying, hey, I have pain, my residual limb or my phantom pain is acting up, and I'm like, okay, let's do this. Is there pain, right? Be methodical, and it's very easy, right? It's very easy. You're like, okay, all supplies doffed, right? You're at rest, nothing's on your residual limb. Is there pain? People are like, no. Okay, all right. You just have a shrinker on, right? At rest, is there pain? No. Okay, all right. just the liner. You put on your liner, okay? You don't have the socket on yet. Are you doing okay? They're like, well, it starts to hurt a little bit. It's like, okay, right? You put on while you're donning your socket or after you've donned your socket, right? Upon donning your socket, you're sitting it out. You're at rest. Is there pain? They're like, not really. It's like, okay. Then you're like, upon standing, right? Is the onset of a discomfort or a pain immediate, right? Or is it one of those things that it's like, several, an hour and a half later into the day, right? Are you doing the appropriate sock supply management, right? Now, pain when I'm putting weight on it, it's like, great, great, great. Little more detail. Is it when you're putting the leg in front of you and it's becoming the accepting limb in a sense, and you're just about, every time you put your prosthetic heel down, it acts up? Is it when you're standing right over it, when you put it past you? Little more information, right? You're like, oh, it hurts the inside of my knee, and it only happens when I'm like directly above it. It's like, yeah, okay. Well, that gives a little more information, right? You know where to look, you know where to correlate some of these things, how to make sense of them. You're building a story, right? So it's really important to know how to take a pain history. Please care about this and start doing it more methodically. It's good to know what to communicate to other providers as well, right? Okay, all right. So we're talking about post-amputation pain syndromes today, and we're gonna have two broad buckets, okay? So phantom sensations aside, and we'll talk about those more a little bit as well. Residual limb pain. And this, obviously, like we talked about, pain in the residual limb itself, right? Okay, a lot of the times it's just that nociceptive pain, right? So, uh, strained or damaged structure, in the actual residual limb. And we'll see what some of those causes might be, right? Don't forget though, right? It may still have, they're like, and it burns. It burns right here. It doesn't refer down to the phantom, but it can have neuropathic qualities to it, right? Okay, so versus the phantom limb pain, right? So this is where we have that ghostly phantom, representation that lingers, and we'll see why and how. And then, even then, by the way, it could be patching its distribution. People may only appreciate these free-floating, patches of the phantom. We'll see some pictures as to that from the original kind of reports. And the point is, it's like, yeah, even the phantom pain, it's like, I want to know what the distribution is. It's like, it's my foot's on fire. It's like, what part of the foot? Like, what does it matter? Like, actually, it matters. It matters where I'm going to go look, right? So is it the top of the foot, right? Like, is it the back of the calf? Is this burning pain? Is this like, electric shooting pain? What is it like? I want to know the qualities and the distribution, right? Because it's going to help guide if I can correlate the physical exam, for instance, the distribution of a remaining peripheral nerve that's irritated, etc. It's really important information to have. So pain is not just pain, like it's got dimensions of descriptors, right? Localizing effect, right? Okay, all right. So let's focus in a little bit on the residual limb pain. Okay, the most common cause of this is actually going to be a neuroma, right? And or nerve entrapment in scar tissue and or repetitive nerve microtrauma. So let's understand a little bit about what's in play, right? Because none of these things should be black box. I don't know. That's something the physician deals with. It's like we communicate, right? We need to frame for our patients, and we need to understand what they're going through, right? And why certain things are being recommended, etc. So stump neuromas, right? Neuromata, right? Like they occur at the end of a severed major nerve and are clinically significant cause of post-amputation pain. The damaged axons axon sprouts grow into surrounding scar tissue and regenerative response to the nerve injury forming neuromas. So here's the interesting thing about neuromas, right? Depending on how the nerve is treated at the time it's resected, surgically, what the surgeon sort of does to it, where it comes to lay in the soft tissue envelope and everything, it really matters, right? So that operative handling really matters, and we'll see some evidence as to that. Okay, everybody's resected nerve, assuming a typical traditional, standard amputation, procedure with no neuroplasty at the original time of amputation, no special handling at the end, they will end up developing a neuroma. Okay, so it's almost like a bone that breaks, right? And the two pieces kind of form a bridging callus. So imagine that the nerve, almost like a rope, gets cut, it frays, right? And it fetches up in scar tissue. It's trying to actually find the other side to connect to, right? And attempt some sort of repair, but that repair is aborted, right? Like, there's nothing to connect with. So the nerve end does need some special handling, right? So a lot of the times I'm assuming care for people. I kind of want to know what the operative report showed if there was a neuroplasty that was done. Okay, so here's what's going to happen, by the way, right? So this is what's known as a Tinel sign. So if you have a nerve, any peripheral nerve that's giving you fits, right? Like you're assuming that's the mechanism, right? It's neuropathic in nature. Percussion, right? So just like tapping on it, right? Tapping on it, oh, that's gonna set that thing off. Okay, people are gonna be like, yeah, quit it, quit it, quit it, quit it, quit it, quit it, right? They're like, yeah, that's my pain right there, right? And so it's important to know the distribution, right, of the peripheral nerves, how they course through that particular limb segment. So a lot of the times I'll feel high up, like somebody's the back of the thigh, the back of the knee, somebody's sciatic nerve in a sense, the tibial distribution, common fibular distribution. Like I'll tap on the different distributions. People are like, yeah, right there, right there, right there. Okay, here's what I mean to say, by the way. Everybody's resected nerve stump, in a sense, has a high likelihood of developing a bulbous end. The nerve is still alive. The nerve cell, it's in the dorsal root ganglion, close to the spinal cord. It's still making stuff that it's sending down the wire. You have accumulation of material over time, responsive changes to the connective tissue surrounding it. And the problem with that is, now, you're going to have a mass effect. Most of the time, though, if you watch by ultrasound, right, like what happens to people's resected nerve ends, right, they get more bulbous over time, over years and decades. But most of the times they're not symptomatic. It's like where they came to lay and rest, even under compression of the socket, nothing really kind of compressing it, smushing it up against the bone, hard surface, etc. So people are doing good. Just seeing a neuroma, right? And you can elicit, by the way, sensations, right? But people are like, yeah, no, it feels funny when you kind of hit me in that spot. But for the most part, it's non-debilitating to them, not with socket use, not with exacerbated phantom pain, residual limb pain, or anything. So it's like, let it be. There's no need to go after that, okay? So we have neuromas that are non-symptomatic, right? We're talking about symptomatic, where they're there and they're giving them grief, right? So, and this is effectively, right? So imaging is the mainstay of the identification and localization of symptomatic neuromas, right? So you're correlating history, right? And physical exam. You're like, that's where I expect to see it. And lo and behold, you get the ultrasound, right? And you'll see the bulbous nerve end, right? More so, the MRI is the investigation of choice, right? So it'll just light that up. No contrast required, depending on the sequences that are being typically done and affected, right? So, and it's good because then the imaging can also help frame potential discussions for surgical planning, right? So, but do start feel comfortable to basically say, hey, Tinel sign, like percuss, like is this? You're like, yeah, that's kind of setting it off. All right. So what happens to transected nerves, right? Like we've been doing amputations forever. Okay, so this is a report from way back in the day, and I love these original reports. Like this is like 1920, right? It's like, all right. So Dr. Hubbard et al. With Dr. Lewis, way back in the day, they looked at histologic examinations, right? This is what they would see, right? So this is quite literally, a nerve stump, right? Like that's developed a neuroma. And what you end up seeing, right? So here's one, right? That, it's not, it's slightly deformed because, as they mentioned, the shape of a neuroma may be modified by pressure, right? It's responsive, right? When lying on bone or tendon, it may be flattened while the side enlarges where the resistance is less, right? And effectively, if you look at these under higher, magnifications, what you end up seeing is that a neuroma, again, like we said, it indicates an attempt which is thwarted or blocked by scar tissue on the part of the neuraxes, right, the axons, of the divided nerve to seek the distal segment and complete nerve repair. These regenerating neuraxes then either form spirals or irregularly distributed and dispersed fibers in the bulb. These in their growth stimulate connective tissue to increase and continued growth. And it kind of, like we said, nerve cut, frays, right? The axons fray, they spiral out, and they fetch up in scar tissue. That's not a good thing. So proper handling of the nerve stump at the time of the original amputation, very important. Okay. So it's good to understand the mechanism. And you're going to hear a lot more now and in the coming years. So this is something our plastic surgeons have started doing at Vanderbilt for the past like 3 years now. And it has been really good, really, really good. Talking about, so our plastic surgeons have started doing this procedure known as a peripheral regenerative nerve interface, RPNI, or regenerative peripheral nerve interface. Now, here's the thing. This is how they describe it. This is how it's described in the literature. This is how it's performed operatively. You take a little bit, a slither of muscle, right? Like a deli meat kind of slice, just a little bit. You cap the resected nerve, you cap it and you suture that in place. My question is like, wait, so is that thing viable? Like, does it die off? Like, what happens? They're like, no, no, no. It's thin enough that you get capillaries growing into this and sustaining it. But lo and behold, what seems to happen, right? Like these things remain viable. The nerve sprouts connections. It's adjoining these nerve fibers. It sprouts connections into these fibers. And as far as the nerve is concerned, it's handshaking with something it knows how to interface with, muscle. So it's making a new neuromuscular junction, right? And it's as happy as a clown, right? So you have a new neurophysiological terminus, right? In the, handshaking with those muscle fibers. And the chances of this now giving you fits or developing a neuroma down the line, way, way decreased, right? Like, so this, our plastic surgeons reached across the way. They spoke about the technique to our vascular surgeons, and they're like, "Do you want us to scrub in with you guys? Like, we'll, and they're like, no, teach us how to do these." And now we've got people and vascular surgeons who are basically doing these at the time of the original amputation, right? It's been a great development. These are also being performed for people who have symptomatic neuromas, right? Whatever the nerve handling and treatment was originally, if we have a symptomatic neuroma that we localize, so patient history, physical exam, MRI, imaging, everything kind of points to, yep, that's your culprit right there. The surgeon will look at it and says, yeah, I can go in after that. So they will go in, let's say in a below the knee transtibial residual limb, they'll do is up to, right? Like they will go in after one target that we can see. They said we explored the other ones and like they needed doing as well, right? So they'll do up to like five peripheral nerve neuroplasties in the transtibial residuum. Interestingly, right, so patients come out of that, and these are people, by the way, who are committed to this, like they say, yeah, I kind of need something done, right? Because they're like, socket intolerance. And it gets to the point that it's like, something's got to give there. They're like, I want to come off these pills, like I don't want to live like this. And we're like, yeah, you're taking pills to mask a symptomatic neuroma. A lot of the times we talk about this, if I have a clinical suspicion on percussion, I'm like, do you want to basically, trial a wean of your gabapentin? Let's figure out what we're dealing with, and, let's get the imaging. Anyway, and so the point is, people will get these done, and like in the PACU, post-operative, unit, like they'll come out of anesthesia and they're like, oh, like it's gone, right? And sure enough, like they have really good, very minimal downtime for this sort of neuroplasty, and then getting back to their prosthetic fitting, like literally it's like 2 weeks, 2 to 3 weeks later. Okay, all right, this aside, other competing sort of surgical techniques, right? And I have, by the way, data here that basically just show, it's like, hey, they're doing, let's say, here's a 2019 publication, and there's more of these coming out every year. The reason I'm framing the mechanism is that because I want you to know how to make sense of what you're reading, right? And so who was selected for the study? Was this appropriate surgical technique for them, et cetera? And to understand the outcomes. You're like, am I supposed to be impressed by these numbers or not? Or, what was done? Okay, so obviously here's 45 patients with RPNI, 45 without, symptomatic neuromas, and phantom limb pain, right? So very statistically significant reduction, right? All right. So the people who didn't get it developed neuromas. And again, you're like, oh, well, over what monitoring period, right? Like, so this is important, right? Okay, so here's the other thing you're going to hear a whole lot about, because a lot of surgeons are, starting to do these techniques, right? So motor nerve intervention. So this is targeted muscle reinnervation, right? And this is not what many people think it is. Okay, so way back in the day, so RIC, I believe it was Todd Kuiken, right? So electrical engineer turned physiatrist, like incredible work, absolutely incredible work. What was done back in the day, right? So people who had very, extreme upper, proximal upper limb loss, right? The terminal branches of the brachial plexus, right? So they would be appropriated, right? So that you would section the pec, right? Put some fat in between those regions to electrically isolate them, and you would take the terminal branches, dive them in to the different sections of the pec, and now, intuitively, what it's hooked up with, right? So you're like median nerve activation, action subsumed by the median nerve, you would get this lighting up, and if you're doing the surface EMG pickup, then you can basically code for device behavior. Fantastic, right? Very excellent technique. But what's being done now for targeted muscle reinnervation in upper limbs, more distally, and lower limbs also, this is what's actually being done, okay? It's not the, hey, I took a nerve and I kind of dive it into a muscle. What you need to understand is the following, okay? Because it really affects the health of the residual limb and prosthetic training, right, afterwards, right? And you'll see, we'll circle back to this kind of point. You have a motor nerve that dives into a muscle. That's the native motor nerve, okay? So let's say you have a transradial amputation, one of the flexor compartment, muscles, right? It's still receiving its own innervation. Well, guess what happens? They compromise that, right? So they cut it, they snip it. They've got a nerve that dives in right here, okay? So that, they have a nerve that either would have gone to serve something more distal, right? And then there's a coaptation that happens. And, a lot of the times it is as it looks in the picture, you're really hooking up something that's like 5 millimeters to something that's like 2 millimeters, right? And there's a hope that as this matures, some of these fibers, in a sense, kind of bridge across and they start transmitting both sensory and motor innervation. How good is that hookup? So the problem is, like, we've seen the gamut. We have surgeons who also do this, and I've seen patients from all around the country that come to us who have had this done. And so things that I'm anecdotally sort of reporting, right? So this is a me thing, right? Like, I've seen a lot of times where these will fail. So the hookup, the connection, may require a second procedure, right? Because they do end up developing a painful neuroma at the coaptation site. Also, what will end up happening is I've seen the muscle itself. If the handshake of this is not very successful and robust, the muscle atrophies, right? So I've seen people's posterior calf compartments, right, like just become really flabby, and it's like, wait, you're a young traumatic amputee, and your residual limb is looking like flabby enough that as if you've walked on it like for like 40 years, right? So it's like, I don't know, like losing that native, intuitive and time-specific activation, may be something we need to be a little bit more cognizant about, right? And sort of discuss pre-operatively and perioperatively, right? The other thing that will happen is, this is because we'll talk a little bit about cortical remapping, right? So it's like, where's everything represented, right? Where's the sensation represented in the brain? Where's the motor, motor for your motor planning, right? Where do you meaningfully, in a sense, initiate voluntary action? So I've had people who've had an upper limb amputation. They've had TMR done to a number of the peripheral nerves. And guess what? We're trying to fit them and do surface EMG pickup for a myoelectrically controlled, terminal device. And you tell them, you're like, okay, I want you to flex that muscle. And people are like, I can't, right? It's not intuitive, because the native, how you used to volley down that intent to activate said muscle, well, now it's almost like, how do you retrain that? How do you guide retraining voluntary activation to something you've done TMR to is something that's just wildly unexplored, right? And it can posit a little bit of a challenge, okay, prosthetically. So this is where we need to be good about giving feedback in our collective experience back to physiatrists, back to therapists, back to surgeons, because we need to figure out sort of what's going on here, right? So a lot of these studies, clinical studies comparing and contrasting RPNIs to TMR that are coming out, and you'll see, study after study these past, with every year, you have to understand they may be solely looking at the incidence of pain. okay? But not so much how you fare prosthetically and training and meaningful device utilization, prosthetic enablement, those dimensions, right, that we care about, okay? So, all right, I just kind of want you to have a global framing because obviously you'll see, yeah, good results with these, right? Obviously, right? So TMR patients, 3 times higher odds of having lower phantom limb pain, right? And almost 4 times higher odds of having lower residual limb pain, right? But again, what's the monitoring window, right? What happens down the line? When these things fail, they tend to fail early, right? So you'll pick it up early since something's gone awry, okay? Because of that hookup. Okay, the cooptation. Now, it's important when you're reading these studies, like delve into it a little bit. Who did they select? You know, who are they doing it on, right? Because a lot of these studies are not clean. Not every one of these is at the time of the original amputation. Some of these are re-amputations. Some of these are neuroplasties intended. Oh, you got a neuroma? I'll go in and I'm just going to TMR that. Okay, it's like okay. So the thing to understand, the majority of TMR patients reported worse pain. Okay, all right. So 5 patients report severe pain. 4 had multiple failed limb salvage attempts before their amputation. One of these had a peripheral nerve sheath tumor as the primary pathology of their pain. So what is TMR going to do for that? And when we talk about multiple failed limb salvage attempts, so here's somebody who has been living with chronic pain generators. The spinal cord, right, gets so efficient at reporting that pain signal and symptom, right, like to you, that it's like, okay, now it's on a hair trigger. And even after the limb is amputated, that lingering echo still persists. So then, even if you do the TMR, you're like, no, these mechanisms, the effect of like why this lingering echo of pain keeps persisting and minimal activation in the peripheral, distribution still gets reported as pronounced pain, that wind up phenomena right in the spinal cord. It's like, yeah, so don't overpromise to somebody unless you know the history that I'm going to do this and it's going to take away your pain. It's like, maybe it will, maybe it won't, right? You need to be really upfront. So, and again, this is why we care about pain. I don't want anybody being lifelong on like gabapentin. They're taking it, and masking things that need timely intervention, because once you have chronic pain, fetching up in the body, it's very difficult to extinguish, right? Okay, another patient had a history of an ischemic injury to the distal upper limb, right? So history of severe chronic pain for years preceding amputation and TMR. So these may be poor candidates in a sense to get benefit out of the subsequent neuroplasty, right? Okay, so we have to understand like what's being done on when and to whom, right? So we have to understand our substrate, our patients. Okay, residual limb pain. So back to this. Second most common cause is going to be soft tissue inflammation, edema, right? Stump bursitis. Effectively, this is what I'll do with patients, right? So I'll show them like, hey, you see how, your elbow skin, kind of moves freely, over the bony prominence. It's like, yeah, we got a little fluid-filled sac. It's collapsed for the most part. Minimal fluid in there. It kind of allows things, to slip and slide past each other, right? Okay, good. Guess what happens? We can develop these things anywhere in the body. Anywhere if you've got unchecked motion, right, of the long bone of a residual limb, or you're coming to contact a certain surface and there's relative motion, there's shear tension on the surface, but also deeper, right? So what you're going to end up doing, right, the mechanical conflict between residuum and socket results in a range of inflammatory conditions consisting of localized soft tissue inflammation, adventitious bursa, bursitis, and bone marrow edema, bone bruise, which we'll see again. So you can develop like a little fluid-filled sac, a potential space that, guess what? Same as like, student's elbow. Like if you damage that, right? If you keep on aggravating, if the long bone is moving around in there like a meat grinder, like a meat pestle, right? It's like you're causing deep tissue injury as well. You might not see it on the surface, but it's definitely there. And what happens is, guess what? That fluid, right? It can actually increase in size, right? And then be really painful. Effectively, it's a sterile inflammation, right? So to complicate things, right? Obviously, if you tap on it, right? Yeah, people are going to report pain. Is this a neuroma? No, very different qualities to it. It's just localized pain. And people can kind of tell you, no, it doesn't have neuropathic qualities to it. So there's that. So the clinical presentation is going to vary from mechanical pain, right, inflammatory manifestations, erythema, swelling, local heat, and variation of stump volume, right, to a fluctuating palpable mass, right? Okay, what do we do? So x-rays, very good place to start. It may reveal contributory osseous abnormalities. So here's a little spicule there, right? Like in the ultrasound is saying, yeah, you got that little spicule. And by the way, you formed a little fluid-filled sac as seen by ultrasound. The mainstay again for bursitis, the imaging study of choice would be to get the MRI, okay? So critical cornerstone, how do you deal with this, right? Like prevent prosthetic socket modification, reduce the mechanical friction over the bursa, right? First line intervention. So prosthetic holiday, let things calm down, right? Like quiet down. And, right, okay, prosthetic holiday, icing, compression stocking, elevation, NSAIDs, right? A topical if it's kind of close to the skin, rather than taking systemic. Very good places to start. Let things calm down, because if you refit too quickly, it's like, oh, this was about to heal and now we re-aggravate it. It's like, boom. Oh, okay. So, and yeah, and that's to extinguish that down there. All right. Next, at the end of the residual limb, bone spurs, right? Like at the resected end of a long bone, for instance, bone spurs, aggressive bone edges, right? So it's good to know that they're there, right? So if you have a suspicion, get the x-ray, know what you're sort of fitting around, right? So not everybody performs the amputation surgery the same, right? So in terms of beveling the resected edges, and a lot of the time, these are the result of like periosteal stripping, right? So, and then the bone sort of like oozes out in a sense, and forms a spicule right there. Sometimes it's done under the guiding pull of like, was there a myoplasty, a myodesis, anchoring sutures, pull, line of pull. Sometimes, you may end up seeing something like this in response, depending on how the periosteum was treated there. Okay, so they're focal, right? People are like, oh, it's right there, right there, right there, right where you're touching, right? It's like a knife edge, or it's like a little point, right? It's like a needle inside, underneath the skin. And sure enough, you pinch between this hard, spicule and the socket, right? Poor socket tolerance, and even overlying skin ulceration. So some of these really may need, operative management and, going in rebeveling, right? And recontouring the bone. Okay, so constantly trying to, if you don't know what we're dealing with, it's like, yeah, let's send them back for a medical evaluation, get the x-ray, know what you're dealing with, like before. Obviously, we're not committing everyone to surgery willy-nilly, right? But you also don't want to be committing people to prosthetic refittings in vain, okay? All right, so yeah, this is what they'll kind of look like on x-ray, obviously. Now, let's not forget our heterotopic ossification, right? Okay, so common and problematic clinical entity of post-traumatic, not just traumatic, but mostly post-traumatic, right? Ossification in the soft tissues that limits and delays early rehab. So these are spicules of bone, in a sense, like little eggshells that are going to slowly form, right? So blast injuries, right? Sometimes if there's also some neurologic injury associated with a polytrauma that may have brought all this on, uh, uh, and the heterotopic ossification could happen close to the resected end. It could happen proximally around the hip joint, around more proximal sort of joint. So it's very important to know. A lot of the times, they're going to be in the soft tissue envelope. We're trying to compress and fit around, right? So, and it's an evolving process. So these things, right, like as they're slowly forming, it may take upwards of like a year to a year and a half for these things to mature, all of these little eggshells, right? So it's like, when do you check in with what? You can get the x-ray early on. You're not going to fully appreciate the burden, the HO burden, right? And a lot of the surgeons, they know if they go in after this and try to carve it out, guess what? It's just going to come back. First of all, it hasn't fully matured and fizzled out for you to know the cumulative burden and then go take that out and hopefully nothing comes back. There's many different aggressive treatments for this, right? So people will do, for instance, like radiation therapy, to sort of whatever's like fueling this to try to arrest it, right? High dose NSAIDs, right? Like almost like gout level medication, like indomethacin, things of that nature. There's also, but you want to keep doing the muscle activation, prosthetic supply dawning to comfort, right? So the patient's going to let you know, hopefully communicate to them. It's like, there's things that I can tolerate and sort of work through. And then there's, ouch, I'm doing damage to myself kind of thing, right? So it's like, that's what we need to know. So again, a lot of the times this takes a long time to sort of, fully declare mature. People get fitted prosthetically just fine, right? So it's not one of those things, not every one of these needs to be carved out, intended to, right? We have people who have extreme burden, really impressive x-rays, who are doing marvelously with their prosthesis, right? Okay, so majority of postoperative infections, right? We're gonna give you pain in the residual limb, right? Cellulitis, characterized by swelling, pain, local erythema, right? High resolution ultrasound may reveal soft tissue inflammatory changes with and without drainable soft tissue collection. X-ray to exclude the osteomyelitis, bony involvement, right? In addition to systemic antibiotics, right? The condition is successfully addressed with local wound care, debridement, dressing, optimizing the host defense, diabetes control. Wound healing may be delayed owing to deep-seated sinus. So this is the one thing I do want you to kind of care and worry about when you see an organized tract, right? That's chronically draining, right? Well, if it's not infected yet, it's gonna be, right? So, and tracts that don't heal up in a matter of like weeks, right? So you organize basically the lining of the tract, right, has organized a type of tissue, right, that guess what? It's almost like the inner part of the mouth, right? It won't close up. You bring that thing, even if it doesn't have fluid in it, the walls collapse, but they can't heal across. So this is why a lot of the times, in terms of managing a sinus that's organized, right, you need to go in and surgically disrupt that wall so that then healthy healing can happen across and close it shut. Okay, so obviously MRI is going to give you kind of a more fuller picture of like the local involvement, right? Aggressive wound monitoring, right, is recommended in all patients. And let me tell you, I know we let people sometimes get away with small wounds and everything's like, yeah, they're being brought into the life, right? So I know you may not be worried so much about young, traumatic, patient with traumatic limb loss, right? And you're like, yeah, they know what to do. Like they'll do a relative prosthetic holiday. They'll put their neosporin on there. They'll be fine. It's like, yeah, we do want to give them a sense of, impart the importance, right, the urgency of and seriousness, gravity, because guess what? How we're framing these things for them now, they're going to be dealing with 20 years down the line when they systemically, if their immune system has waned, they're still smoking, they're this, that, the other. So it's like, yeah, let's teach them the seriousness of these things up front. And obviously, right, we have so many patient subpopulations, right, with a lot of different comorbidities, like, so that your, diabetic patients are going to be much slower to heal. So you got to be really on them about that prosthetic holiday, getting to the wound care, etc. Right? So this is another thing. You guys have the most exposure time to the patients and for opportunity for intervention, education, etc. Right? And proper framing for all of these things. So we need that collaboration there. So once we have bony involvement, right, constituting osteomyelitis, this is local spread from neighboring soft tissue infection that fetches up in the bone, right? So it could be blood-borne spread, right, or late occurrence of a clinically occult septic focus, right? So something may have fetched up in there, and guess what? It's been 3 months since the amputation, and now why are they having pain? We didn't have any skin breakdown or anything. It's like, yeah, it was an occult, a little hidden site that was there, and now it's kind of like blooming back up. So osteomyelitis requires higher surgical revision in addition to antibiotic therapy when compared with soft tissue infection alone. This is why we really care. Things are very close to the bone a lot of the time. So it's like, treat these things seriously, right? Obviously, take pictures, send them to their referring provider, and basically be like, hey, heads up, what do we do? You want to see them? Should they be on my radar? I'll get them back in next week. These are all actionable things, right? So nothing of what we're talking about today should be academic, right? This should be mechanistic understanding to nuance what we communicate, right? The stories we tell patients so that they come into the know for what needs doing. All right, so bone scan is going to be sensitive, right? MRI, obviously, and for the osteomyelitis and bone scan. Now, bone scan, will show you the local inflammatory reaction, whether it's bursitis, whether it's this, it's non-specific. MRI is more sensitive, and the CT may be useful in detecting small sequestra occult to MRI. Okay, stress fractures and bruises, right? Different things. So here's an interesting one where, because you're not going to have soft tissue involvement, right? So they're loose in their socket, they're kicking the front of their socket, let's say transtibial, right? Distal anterior aspect, right? And they're like, I got pain right there. And you're like, okay. If you do the MRI, the soft tissue envelope is fine. You're just seeing increased water content in the bone, right? So there's your bone bruise, right? Okay, so, and the thing about this is, what do you do for this? Prosthetic socket modifications, like just make sure, they're not slack in there, so there's no permitted movement, because that's just going to keep on happening, right? Are they doing appropriate supply management? Do we need a major, recasting, refitting, etc.? So, yeah, reducing the mechanical load at the pressure points of the residual limb is the treatment of choice. Obviously, we can always, verify with an MRI, to make sure that we're not dealing with anything else, because so many of these things, right, they present indistinguishably, right? So this is why the story matters. How did it come on? Are overlying skin changes, anything else going on? For us to figure out, like, are we dealing with a bone bruise, a bursitis? What are we dealing with here, right? Okay. So local tumor recurrence, obviously, for those cases, right, may present as residual pain. X-rays are first line, especially if we had history of cancer, should always be in the back of our minds, right? Because a lot of the times we think this is prosthetic, right? You're like, oh, it's a bone bruise. Like, we're gonna, let me offset this. When it's a patient with a history of cancer, this should be really high up there for us, okay? And yeah, X-rays first line investigation, you may see some lytic, or either sclerosing, like more deposition of bone, or lytic, like, dissolution of bone, demineralization, due to the space filling effect of a tumor. And obviously these things are going to light up on the different MRI sequences. Now, however, the thing to remember here that I want you to be, it is very important to remember, there's many other things that can do this, right? So I recently had a case of a lady who basically, transfemoral, limb loss and pain at the end of the residual limb, right? And it's like, and to look there, there's nothing there, save for the fact, guess what she has developed, because of her other medical comorbidities, avascular necrosis of the femoral head. So the femoral head was dying off, and what it sent down in a deferred pattern was the lingering echo of this pain was manifest, and she couldn't appreciate this pain. She appreciated it as pain down, at the end of the residual limb. If you can go chasing after that prosthetically, but it's like there's nothing to do for it, right? Like it's a whole different area of focus that needs attention. Okay, so this is why these things matter, and it's like, yeah, just tag someone else in for the co-evaluation there. All right. This is we're switching gears now to, okay, what's this phantom limb syndrome about, right? With and without pain, right? So I want to frame all this for you so we have a good understanding. And, okay, so here we're looking at our central nervous system, brain and spinal cord, and peripheral nervous system, right? So everything that's outside of that. Dorsal root ganglia, autonomic, peripheral nerves, the works, okay? This is what we need to understand though. Phantom limb syndrome is a broadly distributed phenomenon, right? It affects the entire nervous system. So the moment you have the deafferentiation, right? So a limb segment is gone. Oh, the brain goes, oh, no more input, no more input, no more input from that region. Ah, right? And things go haywire, right? So there are events, right? So understand that it changes dynamically. There's early events and late events to this process, right? And it requires different interventions at different sites, here, right? During opportune timeframes, like miss the window, and some of these processes fetch up in there, right? And they're hard to extinguish afterwards. Then you're playing catch up. So this is, and we're not all there yet, right? So as a field, right, we haven't done the cross-pollination of expertise, the interdisciplinary collaboration to figure out what we should be, queuing up front to make sure patients don't develop any of this, right? So we'll talk a little bit about this. So early events, right? So obviously, massive tissue and neuronal injury, right? Resected nerve end. Depends how the surgeon treats it also. Hyperexcitability of those resected axons, spontaneous discharges, right? Well, guess what? Increased neuronal activity in the cortical representation, right? Expansion of neural fields, which I'm going to show you what that means, hyperexcitability, and loss of descending inhibitory pain pathways. This is what we forget. It's almost like you enter a room, then you sort of, there's a smell, and then you slowly sort of tune it out, you acclimate to it, right? It's almost like, yeah, I'm registering this. I acknowledge, I want to dampen, sensing it. Also, if you have pain in any structure, right, you change behavior, but also there are descending, going from the brain on down back to the limb, inhibitory pain pathways. And that arc gets lost, right? Because there's no more input to send that down to. And, so the major circuitry is being disrupted up and down the neuraxis, okay? Then you've got in the spinal cord itself, sprouting of non-pain neurons in the dorsal horn. I'll show you a little detail on that. Increased NMDA receptor activity mediated by substance P, tachykinin, neurokinins, and the dorsal root ganglion, which we'll see another picture of, so it sits right outside the spinal cord at every spinal level, right? So this is your sensory, these are your sensory neurons, okay? And they're bipolar nerves in that they have two poles, right? So one goes straight down the wire all the way to the foot, so to speak, right? And the other one goes all the way, it goes into the spinal cord where it communicates with other interneurons that then ascend up to the brain. So the dorsal root ganglion is a very big spot for where people now believe a lot of the phantom limb syndrome is responsible for. So there's a complex interplay immediately, early events, right? So central, peripheral and central sensitization. Transduction is basically the converting mechanical pressure to electrical activity that gets coded and volleyed up, right? Or thermal, right? Or, or whatever, or chemical inflammation, right? Like, inflammatory substances that then get coded in as nerve impulses and come up. So transduction gets affected, it's very much in play. Transmission gets affected, perception, right, gets affected, and modulation of all of these is in play, gets affected. Chronic events, what happens long term? Well, there's cortical reorganization, which we'll see, right? Cortical motor sensory dissociation, an abnormal neuromatrix, which is a very interesting idea to sort of define, right, and wrap our minds around. And there's limbic. Your limbic system is your affective, your emotional system, right? There are people who, listen, it's like living with pain is no joke. This is a level of suffering, it's like we need to be cognizant of that, because depending on what else they have going on, are they adequately enabled, just living and just keep tasting that pain, teaspoon after teaspoon after teaspoon all day long, in a sense, like that is misery, right? And it can lead a lot of people to, associating anxiety, depression, catastrophizing, right? And guess what that scuttles? Motivation. Good luck getting them to do something, right? When this is the only reality, suffering is the only reality they know, right? So we really want to get ahead of this, right? So spinal cord sensitization, right, and wind-up phenomena. This is the chronic pain, in a sense, where, like we said, you keep volleying up the pain information, you get really efficient, right? So nerves that wire together, fire together, you get really efficient at like coding that message and sending it out, even with minimal input in the periphery afterwards. All right, so the dorsal root ganglion kind of goes haywire, right? So it's almost like absent the terminal thing it was handshaking with. In the middle, it sort of increases its activity and it volleys information up and down, right? Like by like 70%, right? So it just like starts to just be trigger happy and finicky. It's like, okay, so ectopic regulation of neurotransmitters, and then what's known as deafferentiation pain because of the loss of the inhibitory, descending the inhibitory pathways and neuroma formation. Some models, right, that people, none of these are the word, right, like, but they're useful approximations, at least to our current mechanistic understanding, right? It's not about getting mind locked into these things. They're a way to describe what we think is sort of going on. So cortical remapping is one of the theories, right? So it's not just a hypothesis, this is a theory, so more solid evidence, right? So it's really hard to shake this because there's a lot of good evidence for it. And this is what we're talking about. Here's your brain, right? So you're going to have a motor strip and a sensory strip, right? So primary motor cortex and primary somatosensory cortex, and the whole body is represented. It's got very specific, the organization is reproducibly there. It's like this in most every person, assuming normal typical development of the brain and the entire neuraxis, right? So here's what happens, right? So you have somebody who has, let's say, an upper limb amputation, right? And they may describe a telescoping phenomenon. They're like, oh, I feel like my it's there, but it's getting shorter. And it's like, yeah. That's prime neural real estate, right? So other areas that serve the face, for instance, they start encroaching. So the perception is like, oh, something weird is happening to the residual limb. So effectively, can you see evidence of this? Can you see phantom, right? The phantom phenomenon, right? Yes, for sure you can, if you got the right tools to look, right? So here's cortical mapping, right? Of like the finger representation in somebody. And after, let's say, digit 3 is gone, right? This area, the green area, gets taken over by 4 and 2, okay? Neighboring, right? That they're organized and it's prime neural real estate for processing. Okay, another thing that happens is the neural matrix representation, right? So this is interesting because this is where, let's say, things like mirror therapy and virtual reality come in. The thing to understand there is like, how do you know where your arm is, right? That this is your arm. Well, you're integrating proprioception, internal wiring. That's not good. That's not good enough, because if you just close your eyes and you try to accomplish anything, you're going to miss the mark more times. Visual input, right, for where the body is in space takes precedence because it's more immediate and more successful, right? So we have a better sense. Visual input, for instance, people who have a sensation during the cortical remapping that, oh, the hand is in a clenched position and it's very uncomfortable and distressing to me, you throw down that mirror, very guided. You have to be very deliberate and guided to getting them to look at the intact limb, opening and closing, and they can declench the phantom, right? Because it's a trick of the brain. The brain prioritizes visual information over actual proprioception, right? So in a select subpopulation of patients, it's not for pain, it's for sustained, weird, distressing, positioning. It can work wonders. Same thing with virtual reality. So you are in your mind, you're a point density cloud, your probability matrix, right? Like of where your limbs actually in space, made real by interfacing, bumping into things, visual input, proprioception. And point of fact, you can switch that up on people, right? So initially the concept of a neural matrix, right? That virtual representation and how it's lax, dynamically it's lax, it's fluid in real time. So look at this. See, these are representations of phantom limbs that people reported, and the dashed lines are the part they sense. And so here's somebody with an upper limb, they can sense a clenched fist, and in space, in the relative positioning to the residual limb is this, right? Because of whatever cortical remapping has taken place. So the dotted may be absent, but this is where it is and where I feel it. Sometimes they feel it right in the residual limb, right? Or patchy blotches of distribution of what's appreciated. Sustained positioning, maybe, and what happens in the periphery really affects what happens up top, right? In the perception of the phantom limb, right? So this is why there's interplay between residual limb pain and phantom pain, right? And changes, injury, inflammation, because here's somebody who had, I believe this is probably like a Krukenberg kind of procedure. And, the splitting afterwards, like they had an intact phantom hand, and following this, the phantom was split as well. It's like, okay. All right, so the experience of a phantom limb has the quality of reality because it's produced by the same substrate that gives you your typical subjective experience, right? So of course, if like it's in my head, I'm like, listen, this is real. This is very, very real. So what about typically able-bodied condition, right? So to understand, like I said, this is your perception of where your limbs are in space. They're like a trick that's constantly dynamically being told by your brain. If you were to do mixed virtual reality where you obscure, okay, you almost make it seem like you had an amputation, right? Guess what? And we ask you with a slider to like estimate where your thumb is, right? You're actually going to think that your thumb has moved closer and closer to the end of the phantom residual limb, right? It's like you think you think you're intact, but it's like it's a trick that's sustained, right? Okay, so phantom limb interventions, obviously deep brain stimulation, right? Repetitive transcranial magnetic stimulation, that's more experimental right now. Tractotomy, cutting nerve tracts. Mirror therapy, virtual reality, spinal cord stimulator, cordotomy, again, cutting tracts, neural tracts in the spinal cord. Dorsal root ganglion stimulator, we'll see one, cryoablation, DRES lesioning, RPNI, TMR to the resected nerve end, collagen nerve wrapping. There's about 150 different techniques that have been attempted to how to handle the nerve, dive it into a neighboring vein, number of things that have been, but right now the two games going are RPNI and TMR and collagen nerve wrapping. So revision surgery, radiofrequency ablation, blocks, peripheral nerve stimulator, and TENS. Obviously, medications, prosthesis, prosthetic training. Here's a spinal cord stimulator. Here's the dorsal root ganglion, like that gets implanted for a trial because the patient says, this is the distribution I feel it at. You're like, oh, that seems to be L5S1. So you go after those levels, or L3, L4 right here, and so you put this next to the dorsal root ganglion, you activate, differentially, and they say, that took away 50% of my pain. Okay, good. Also peripheral nerve cuff, right? So imagine wrapping this surgically around the sciatic nerve, and somebody can get on their phone and activate it. They're like, I wanna like depolarize this nerve. It's giving me fits. So for the next 6 hours, they're good. Okay, so phantom limb pain. What is the protecton, right? So what interventions should we bring to bear, right, to protect from this ever giving people grief? It looks like, okay, so the protecton is a notion from like transplant medicine way back in the day. It's like you irradiate the whole body, you knock out hematopoiesis, right? All red and white blood cell production, you're gonna die very quickly. So for people who we had to do that to because of a leukemia, for instance, and then giving them back their own cleaned out marrow, right? It's like, what's the minimal amount of cells you need to give to reconstitute? So that dose was called the protecton. Well, when it comes to obviating, right, decreasing the chance for phantom limb syndrome, the protecton is not one single thing you do. It's many things you do, right? And they need to happen in the opportune window. So this is what we ought to be doing, okay? And so for early events, perioperative education of the patient, right? Peri-op peripheral nerve catheter, RPNI, TMR, collagen nerve wrapping, epidural anesthesia. So the neuraxis, right? The entire central nervous system does not register the insult perioperatively of that resection of the limb. Epidural anesthesia, and there are certain medications, right, that if you give them early enough, right, they get things chill out, right, and it's opportune to do it, right, because then, like again, you don't register that insult, right, so you decrease the chance of long-term potentiation and spinal sort of wind-up phenomena. What are we doing on the back end, right? Mirror therapy, virtual reality, prosthetic fitting and training, timely, right? So we don't want to wait, and I don't want to hear about like administrative, even administrative delays. It's like, we'll see somebody, they're ready to go, we'll give the prescription, it's like 3 months later before we see them back, and they're like, nothing's done yet. It's like, okay. So your timing matters, right? Your input, your caring, and your like shoring up those things really matters. So psychological support for them as needed, right? And who these patients are, right? Let's talk about it. Let's make sure we get them help, right? So medications, right? Obviously, residual revision surgery, surgical interventions, devices for intractable phantom limb pain. So all of these, so it's not a one and done, it's like it's all of these and throughout, right? So that needs a lot of like, cooks in the kitchen, right? And they all need to be talking to each other, and they all need to be on the same page about what needs doing when, because we're doing a mismatch of these things. So this is why you need to get an interdisciplinary continuum, a spectrum of care in a major academic center, private practice hospitals, et cetera, and or send people back to providers who are in the know about all this, okay? So I had a really weird, so we're gonna talk about the weird stuff a little bit, because you need to understand what people's experience is. Now that you understand mechanisms in play, right? This is the proper framing, right? For what happens. I don't want this to be a black box. So I have a patient who has an amputation, transtibial, goes back to their surgeon and tells the orthopedic surgeon, my nub's on fire, right? They're like, every time I pee, every time I poo, right? Like even when I have an ejaculation, they're like, my nub's on fire. The orthopedic surgeon's like, yeah, you got to go see neurology for that, right? So the patient goes to neurology, and neurology is like, yeah, we don't know what this is. Okay, and it's like, so I'm catching wind of this because the next time I see the patient for their prosthetic care supplies, right, I'm like, you've had interval visits. I'm like, wait, what's going on, right? They talk to me about it, and I'm like, that's a known thing, right? So here's a publication from 1978 where you can see, lo and behold, by the way, this is what the patient reported: abnormal stump sensation associated with urination, defecation, ejaculation, right? What's going on? So this is taken from the article, so 45%, right, of 33 lower limb amputees, 45% noted that urination caused a burning sensation in the stump end. 30% felt the sensation with defecation as well. 6% experienced the burning with ejaculation, defecation, or urination. So pelvic organ stimulation, activation, basically riling up residual limb pain and even phantom pain. So very few felt burning in both the phantom and the stump end. Only one patient felt burning only in the phantom and only with urination. 50% did not experience any of these sensations. Upper limb were unaffected, except for one who noted burning in an upper limb. And by the way, it turns out, so here's another more recent publication, 2015, in case you think this is rare, right? So cross-sectional study of alteration of phantom limb pain with visceral stimulation in military personnel. So the aim was to investigate exactly what is the effect that visceral stimulation has of phantom limb pain intensity. And what they saw, looking at 75 military personnel with one or both lower limbs missing, they recorded whether they had altered pain, and with what body function. 56% of patients reported a change in the severity of phantom limb pain with visceral stimuli. This decreases over time, right? So there's an improvement over time, right? And highest early on. But if it fetches up long-term in somebody, it's very debilitating, right? So they looked at, and they also noted, like, no, this has been noted as far back, reported in the literature as like 1971, right? Phantom pain with urinary flow. And vascular tone changes, like bladder empties, for instance, vascular tone changes, that can give somebody the tingles, post-operatively. But if we'll talk about what leads to this cross wiring, right? So it's a, say, why would this be happening? So, well, at the cut end of the nerve, right? So nerve laceration is thought to trigger massive sprouting of sympathetic fibers associated with upregulation of alpha-adrenergic receptors in the primary afferent neurons, allowing the vessels to be more responsive to changes in sympathetic tone. And again, let's say you're straining, you're emptying your bladder, vascular sympathetic tone changes, then you start feeling it. The peripheral afferent neurons and sympathetic nerves grow crosstalk between them. So this could be one of the mechanisms. Cortical reorganization, we've spoken about. It's possible that cortical reorganization takes place. The regulatory pathways controlling pelvic organs that exist at higher levels become linked with those that formerly supply the limbs. So, okay, so this is a top on down, the disinhibition. Spinal sensitization. So here's the dorsal root ganglion, right? So these are, by the way, motor neurons for the spinal cord, little rootlets. They join up with the sensory neurons from the spinal, for the dorsal root ganglion, and give you a mixed peripheral nerve, motor sensory. The back here is all sensory, okay? This is all sensory stuff. And they enter right here, these regions, right? And they'll go and make up the tracts from the leg, lower trunk, upper trunk, as you're going up the spine. So they enter these fields. These are called receptive fields, right? And obviously L5, for instance, let's say S1, pelvic splanchnic organs, right? Like, are still going through the same dorsal root ganglion as the leg, is. And what happens is they think interneurons crosstalk here. Okay, so then the deferred pattern, like I have pain in my hip and it radiates down my buttock and my groin, that, for instance, now generalizes more to involve, input and response from pelvic organ stimulation. So crosstalk that happens here. All right, so an increase in muscular tone. It's possible that raised intra-abdominal pressure resulting from bowel or bladder straining increases the tone in the muscles of the amputated limb, right? So this is why relaxation techniques can help, some NSAIDs can help, muscle spasm relaxers, things of that nature. But it's unlikely, right, given the nature of this pain, the character in its nature, it's unlikely that just increased muscle tone is the whole story as we've understood. So based on this limited data set from this 2015 study on the veterans, like what were they on, and postulating as to whether it helped, they've made a little algorithm for, it's like, no, start with this. If that doesn't work, try this. If that doesn't work, try this. But this is, again, not the word. This is not a prospective trial. This was a a guesstimation based on the relative reporting in a very limited sample, right? Okay, the one I need you to sort of worry about, freak out about, okay? Because you've sent me patients like this, right? And it's like I have patients with extreme diffuse generalized socket intolerance. They're like, we've tried to fit them 4 or 5 times, Dr. Bastas. Like, we're at our wits' end. We don't know what's going on. So, and this is somebody whose residual limb is exquisitely tender. These are the folks that cannot have, like, it looks purple, it looks blue, it changes colors, like, and then also highly intolerant of any loading pressure. Like, light touch sets them off, right? It's like, yeah, don't be trying to fit around that. So complex regional pain syndrome is caused by damage or dysfunction to injured peripheral sensory neurons, which has secondary effects in the spinal cord and brain. You stub your toe, okay? You stub your toe, as simple as that. You have a little fracture in the toe, and for some people, they have an innate susceptibility, right? That little local, change, the reaction, the local inflammation, and the reaction of the nerves, right? What it reports to the spinal cord and what gets reported back down, it becomes a runaway process of, increasing the screaming, right, of pain and changing a sympathetic tone to the area. So, we have millions of surgeries, millions of polytraumas. This for 1 in 200,000 people, right? Will end up developing. They have an innate propensity, right, when injured in a limb, for this process to sort of fetch up, right, in there. So you'll end up seeing over time, this is extremely distressing and debilitating, right? Like, very distressing pain. There's nothing you can do about it. They're on high dose of medication, modalities, therapies, them as early enough as they can move, etc. But ultimately, you can have weakness, muscles atrophying because the circulation atrophies, right? Like, you have compromised circulation. The skin gets thin, shiny, hairless, etc. Like, and the problem with this is that you develop it in one limb, it ends up being progressive, so it ratchets to involve the limb ever more distally. So sometimes people will have this, they'll have an amputation, right? But guess what? The process has already started in their spinal cord, and even after their amputation, now progressively later, that generalization across the spinal cord levels, now the residual limb is involved, okay? And they're highly intolerant, right? And it can start happening, it can cross over to another limb, okay? Very, very debilitating. So continuous burning or throbbing pain, usually in the limb, sensitive to touch or cold, swelling, changes in skin temperature, skin color, skin texture, in hair and nail growth, joint stiffness, muscle spasms. So the thing to understand with all this, right, is like, amputations are not curative for CRPS pain. You need to understand whether this is in play for your patient, okay? And we've had, people, like I said, refer to me, and like, we do the, the evaluations and referral to the pain management and everything. Once we understand this is in play, and we're like, yeah, okay. And you kind of have to stop, doing, repeated fittings on these folks. Like, you have to treat what's actually there. So, it's not curative for pain. They may end up needing to undergo an amputation if the limb, the distal limb that's so now atrophied and everything, like, is a threatened limb, right? So if it's going to be susceptible to, wounds, infections, like, then it's a life-saving measure that you do the amputation for. But even then, very poor prosthetic outcomes, okay? And further reamputation of an affected residuum is not beneficial because that runaway process is more proximal in the entire central nervous system, right? So in that distribution, of peripheral distribution to that limb. So just coming up more proximally, it's like, well, it's just, you're just going to see it creep up, so, all right. Okay, so takeaways, right? So residuum pain, right? Reproducibly elicitable residuum pain has high likelihood of being a symptomatic neuroma or soft tissue inflammation. A number of neuropathic processes can posit debilitating limitations to prosthetic enablement and warrant evaluation and treatment. Take a pain history methodically. Pain syndromes affecting prosthesis use, right? And overall well-being warrant evaluation. Let's encourage patients to seek it out. My asterisk there is like, don't just tell them to go to a pain clinic, right? Like, if they're hurried and busy and they're not going to take the time to do a proper workup and figure out what's in play for these patients, we don't just want them being on pills, or failing pills and going to a spinal cord stimulator when something else could have been done, right? So, but we do need evaluations, right? So care coordination is important in planning pain treatments and prosthetic refitting interventions. So we all have to be on the same page, educate our patients, knowledge grants agency, right? So, and decision-making capacity. All right, so 10:30, right on time. And with that, I wanna thank all of you for kind of sitting through that. And I hope it was worth your while. You can always reach me, by the way, by email for any of this content and any questions in general. And here are some references. And all right.
Thank you. That was amazing, per usual. Anybody that has questions can stay and ask questions because we're in a completely different room for the orthotics presentation. So feel free to stay here. I have put the survey in the chat. I'm going to put it in there again, I think. And nobody needs to rush. You can, like Jerry, did you have some questions? And I'm going to hide myself so I can go help Terry get set up. Thank you. Appreciate.
I'm monitoring the chat if anybody wants to type something in, or if anybody is sticking around to ask questions, feel free to unmute yourself and let me know. By way of feedback, I would love to hear if people felt like this was delivered at an appropriate level, right? And you know, if you like the content, and yeah, I can share copies of the slides. Happy to. I will try to get a version of this to Mrs. Mansfield, and she can distribute. Thank you. Thank you for the feedback. I'm glad it was worth everyone's while. Yep. Happy to please reach out by email, and happy to set up like a Zoom meeting, phone call. Absolutely. Yeah, I really do think prosthetists should have greater knowledge of these clinical conditions. It will definitely will allow better coordination of care. We are in the I've been very fortunate to actually have a lot of our local providers have their prosthetic residents kind of circle in during their prosthetic residency. They're sitting in, you know, they're kind of seeing the medical decision making, the assessment. That cross-pollination of expertise has been very beneficial, mutual both ways. And for them to sort of get a sense of calibration, be alert as to a lot of these entities, what needs doing, enough that it actually changes their practices, right? They'll take pictures, they'll communicate things back to me, they'll elicit more history, they'll say, hey, I'm kind of worried about this one, you know, and it works out extremely well for the patient, right? So people are getting timely care and evaluation, and the prosthetists also feel a lot more comfortable, right? Like in what they can bring to bear. There's the same old bread and butter stuff that we can fit around and deal with, and there's the red flags. Like it's good to know about the red flags, right? And again, every patient has a different provenance, right? Like things that have happened in their medical history, right? That bring them with their residual limb to you to care for. And it's good to sort of understand what may be in play, right? So that when there's episodic exacerbations, like is this a disease process kind of acting up, or is this a local issue, generalized issue? So absolutely, yeah. I do think we need to have that cross-pollination of expertise. And you have to understand, right, the more medical providers ratchet up, right, the collective consciousness, right? Like if we practice guidelines, the more physicians know about it, the more patients know about it, you guys need to know about it, because we all have to be on the same level about what's happening, what needs doing, and when, right? So, it's hard to think about moving forward and not being part of the conversation and knowing how to assess some of these things and frame them and educate patients and even encourage them to seek out evaluations. So if something is painful, not everybody's motivated to go see the doctor, right? Because they're like that willful denial. It's like, I don't want to deal with this, I don't want to get reamputated, I don't. It's very important, that behavioral piece, in a sense, to assuage concerns and say, look, we don't tend to this, like, I don't know what this is, it could get you in trouble, or etc., right? Or this is something, this is how this is tended to, and people fare really well, right? So we don't want people to feel like the pain comes with, it's part of the life and I have to put up with it, it's part of being a prosthesis user. It's like, no, there really shouldn't hopefully be any pain with this, right? So you don't have to commit to a life of pills or flying under a certain activity ceiling, right? So that it doesn't sort of act up on you. So then you throttle down what you're doing and you're not adequately enabled. It's like, how's that not a failed outcome, right? So yes, if they're not complaining, it's like, you gotta poke and be like, so pain when, pain how? Like, have you spoken to your doctor about it? Even if that's all you're saying, it makes a big difference, right? They should know that we don't want them. This notion of like, if they're not complaining, I'm good. If they're good, it's like, yeah, don't do that, right? Because they may be living or permitting themselves, allowing themselves a very suboptimal outcome. Okay. All right. Absolutely. Absolutely. So there's very little training that even physiatrists get, there is usually an annual, a gait course, an orthotics and prosthetics course. So they'll typically, physical medicine rehab residents will hear the entire, ACGME required curriculum for their residency training at least twice, right? So some places have an annual, right? So it's physical medicine rehab is 4 years. The first year is kind of like internal medicine, surgical, and so it's transitional year, and then 3 years of PM&R. So they may get the same curriculum 1, 2, 3 times, if it's annual, or if it's an 18-month curriculum, they'll hear it twice. So they'll get a block of O&P, right? So, and hopefully, and it's hard because first they get it early on, they may not be able to orient themselves to what needs doing. And if they don't elect to do some dedicated time in an O&P setting clinic, right, they're aware of terms, they're aware of like some basic principles, but they don't yet feel comfortable stepping into that role to manage care, educate patients. So there really needs to be, in my estimation, like dedicated orthotic and prosthetic fellowship training, tacking a year that's focused and dedicated, because there's a lot to know, right? So this has been a non-starter, right? Because we always feel like O&P is like, it falls in somebody else's purview, right? Like even the physiatrists, like they defer to what the prosthetist, let's say, or orthotist may want to do because, well, surely you've been doing it for 20 years. Like, yeah, listen, there's a lot more that needs to be molded into those conversations, right? About what is advised and why. You have to inform our understanding. We have to inform your understanding and do it respectfully, right? And it's been that inadvertent blind spot in the field, right? This is why our outcomes have been underwhelming, right? So we do need more dedicated training in physical medicine rehab as well. Absolutely.
Thank you for all that information, Dr. Bastas. My name's Chris Savorka. I'm actually part of the faculty at East Tennessee State University, and we're starting a prosthetics and orthotics master's program.
Excellent.
So I wanted to reach out. I saw your message about getting on video and
Yeah.
having an exchange. So thanks for the invitation to do that virtually.
Yeah.
I'm hoping as we develop our program to reach out to other universities like Vanderbilt to offer opportunities to have some, educational exchange. Perhaps having our faculty come up to Vanderbilt to talk with your group about your interests or desires in education and prosthetics and orthotics. And also vice versa for our new students that we'll be taking on in the program so that they can learn more about the perspective of a physiatrist and get some deeper knowledge about these clinical conditions that you were presenting, that you did a really nice job presenting an overview of.
Thank you. Thank you. And happy to collaborate. And again, cross-pollinate expertise, like education has to go both ways here. And even opportunities for trainees or people who have a research involvement or requirement, right? To basically say, hey, if somebody wants to present, right? Or if somebody wants to try, getting their jitters and their blurbs out, because we want them to, before they're done with their training, we want them to confidently be able to, make that script their own, right? Not just be aware of it, right? And there's that awkwardness of like, hey, it's familiarity knowledge, but it's not operationalized knowledge, right? It's like we want them to feel comfortable taking ownership of that conversation confidently, right? And everything. So that's a big part of their professional development as well. So yeah, absolutely, absolutely.
Now, I found that communication is a really, at least in orthotics and prosthetics, communication by the student or the resident in orthotics and prosthetics, being able to talk with the referral source and having a certain level of confidence, or at least trying to overcome the barrier of the white coat.
Yeah.
It seems that the communication requires a little bit more work, at least in my experience in the orthotics and prosthetics profession.
So when you're you have to be the bungling fool, right? Like when you apprentice in anything, and you're going to get it wrong, before you get it right. So what was interesting in my residency training program, like no resident could write for an orthotic prescription, right? Because they want to invite you to engage in the medical decision making. They're like, okay, doc, what would you render, right? And you would be sweating bullets trying to figure out like, is this the right thing? And then even if you came up with the right thing, you're like, whoo, okay. Then like, tell me why, right? But the point was like residents they didn't feel comfortable, to do a proper evaluation, formulate a hypothesis, take stock of impairments, right? Go back to physical exam, figure out what do you need to control for, what mechanisms are impaired, what's an adaptation versus an impairment, to then say, formulate a hypothesis, mock up something, iteratively try, let's say, this is how I understand what needs doing. Let's try it with something that's kind of off the shelf. And if that works well, you're like, okay, now I'm ready to kind of render script, right? Now, it should be done in that fashion. And you're going to get it wrong, in a sense. Let's say teasing gait apart, it's a multi-dimensional dynamic process in real time that's really difficult to do the clinical gait analysis, right? Interpretive framing. So getting people to understand that, having the humility, and then relaxing into, okay, you can develop competence and expertise in it. You have to be invited to do so. And it's okay to get it wrong, right? Like initially. And you are going to have to get it wrong and if you don't get it wrong, it's like you haven't quite arrived. Like it's not quite operationalized, right? So, and I do think that has to be it's a process, right? And we have to invite our trainees to feel comfortable and look at it. And, it's how we engage with them, how we frame things. And, they're always torn psychologically because they need to demonstrate they've been tested to get in our hands, right? And then they feel like they need to qualify that they've got the goods, or they're fully arrived. And there, it's like, no, it's okay, you're an apprentice right now. I want you to get it wrong, and it's okay. But I do want to see by the end, it's like, I want you to feel like you're confidently, you got this, right? So inviting them to read, study, try to operationalize all this, and say, come to me with questions, right? Like, we can spoon feed this stuff to people, right? But it's like, I can explain it to you, but I can't understand it for you. It's very important, right? So
I think you brought up a really good point about earlier in your presentation, you were talking about presenting the current or previous body of knowledge. You started with that to kind of provide a framework, and then you presented a model of information or current level of knowledge. And then from there, you worked on, okay, this is what we know, and this is what I would recommend for treatment. That seems to be a continuing challenge in prosthetics and orthotics, is we have a modest body of knowledge to inform a framework.
Yeah.
So that, a lot of the decision-making is based on, really limited information. I'm talking about treatment decision-making in prosthetics and orthotics is kind of founded on a really limited body of information. So to make up for the gap in that limited information, many prosthetists and orthotists kind of fill it with experience. But then the challenge is, the final product, it's kind of a guess.
Yeah.
So this trial and error, I think the profession of prosthetics and orthotics has been trying to do its best in mitigating error because of this limited body of knowledge. And I guess what I'm just trying to make the point of to the remaining people that are with us, that are enduring all this, is that it's really important for us as a profession, because we have this limited body of knowledge, to reach out to other professions like physiatry, for instance, to help fill those gaps. Like, it's really difficult to work in a silo, particularly if you don't have much information to go upon. So you really need to reach out to reduce your error. And you kind of presented that. What I saw in your presentation is you kind of gave that framework, which we're aspiring to do in P&O education programs, but we're struggling because we've got limited information. So we have to fill the gap by reaching out and having others help us teach. So I will likely be reaching out to you at some point to ask if you would like to serve as guest lecturer.
happy to do it. And again, so the title of the lecture that had been erroneously sort of set up, so I go around nationally giving this talk about like how, a limb loss procedure affects heart and lung function, which is extremely important for, all of our trainees to know. Because it's not very lateralized know-how, and it's actually, scientifically it's settled matter. It's like, it's very important. But the other thing I wanted to talk about, what you had mentioned is, you almost have to, here's a challenge I feel like with orthotics and prosthetics, right? The moment your trainee is done, now they're under an industry interest, right? So now, they're in a profit-driven, marketplace, right? That, and the constraints imposed on how they would mean to act, self-actualize as a professional, what they would mean to do, right? And the constraints placed upon them, that's a really big thing that needs to be tended to. So if I'm just saying, right, like if O&P providers, right, and who's going to be the first one to venture into the space? I don't know if anybody's going to do it from a profit, say, I want my professional assets to have, let's say, 10% of their time, 20% of their time picking up a new skill set. So let me tell you what's frustrating to me as a physiatrist, right? So if I tell a pharmacy, right, a compounding pharmacy, I want a cream and I want 5% gabapentin, 2% lidocaine in there, blah, blah, blah. And I render a script, right? And I send it to them. I'm expecting the pharmacist is competent enough to whip up what I ordered. I can't do that with orthotics and prosthetics. So if I send you a prescription and I say, basically, I want a Marlow anatomical socket on this one, right? You're like, No, doc. Those things are horrible. Like I've heard the worst things. Like, well, if it's not in your skill set, and you haven't just played with it for all of 5 minutes, right? And you don't know how to do it, right? It's like, sure enough, you'll never deliver on one. And I can't say I want a CJ sail on this one. I want a narrow ML ischial containment, and I know what it's supposed to look like, and if it's rendered well, I want, but that falls flat because, like, you don't have professional assets, so to speak, out there in the community that say a couple of people should know how to do, let's say, model anatomical socket, right? Because when one person is out of, redundancy, right? Like, and train on them well enough to be able to render them well, right? When called upon, right? It's like, I can't do that. We can't even have that conversation, right?
Mhm.
So it's very, very interesting. And then who's going to free up assets to train, right? Because then we just lapse into the same mold, right? We have invoicing with particular, suppliers, right? Everybody's, you do these studies when you look at your own field and you're like, oh, it's the same 3 feet. Oh, and they happen to be the highest billable ones, right? Like that you swear by, right? It's like, and the patient, they're locked in, if you lock in what you can bring to bear for the patient, right? In terms of the offerings and whatnot, because it's convenient, because the blind, in a sense, procedural biases, what we operationalize, like posit major limits and time constraints, right? You can't co-localize with us half the time, right? Like, like I would say, I will always invite a prosthetist. I'm like, come here. We have mutual patients. I send them the clinic schedule ahead of time. I'm like, hey, I'm seeing so-and-so. Have you seen them recently? Any anticipated needs? How are they doing? I'll see them, I'll call them up, or we'll teleconference, during the visit, or I'll invite them to be there so everybody's on the same page, right? Because, like, I never want a prosthetist feeling they're going to send somebody to me and Dr. Bastas is going to redirect them, somewhere else. Like, no, this is our mutual patient, right? Let's do right by them, right? You're not looking to sour anybody on their established relationship, right? So very important parameters for, interprofessional conduct, for ethics, for shoring up the training, queuing up the clinical research, right? Because so who has time industry-wide, right? Like to basically say, no, we're going to do large numbers. We have a heterogeneous patient population, so it can't be studies with an N of 10 with a variably rendered intervention. It's like, you can't do that. We're always going to be muddling with unimpressive. So there are ways of how to do pragmatic clinical trials. It's a very different research methodology. Even most card-carrying biostatisticians don't know how to set one up, right? Very different tools, very different setting. We have a heterogeneous patient population with different needs and abilities, right? That evolve over time. So we can't treat them monolithically, right? And even somebody who has a wound is not just somebody who has a wound if they're young and traumatic versus elderly and dysvascular, right? So in maybe the same materials don't benefit, and the materials that I need, I'm above the knee transfemoral, I know that my prosthetic needs now are not my prosthetic needs 10 to 20 years from now, right? When I need more stability dialed in and whatever. Like, assuming I won't be an old, stubborn, bitter man to be like, I want this because this is all I've known, and whatever, right? Like, about bringing to bear what's appropriate, right? So it's interesting. There's a lot that needs doing, right? We are a little bit hampered by, again, the framing of the research endeavor, maybe during OMP training, right? Maybe they have a poster requirement, maybe they do a thesis, maybe they do their master's, maybe they do their PhD in it. And as a field, actually owning up and being like, now we've got big unanswered questions, rather than going for the Star Wars, like integrated sensor, this, that, and the other, right? That's a buzzword that gets you funding, but does not cross-pollinate as expertise, doesn't generalize as practice, right? So, I've got surgeons here who like know how to do a starfish surgical procedure, and I have no prosthetists in the area who know how to pick up after that and fit appropriately, right? So they're like, what do we do? Who do we talk to, right? We need all that. We have to, and for me, having residents, right, here, prosthetic residents and prosthetic providers, keeps informing. I'm not a prosthetist. I don't claim to know the breadth of offerings out there, different troubleshooting solutions, etc. I'm like, I'm enriched, right? Because we'll open it up to the room. I'm like, What am I not thinking of? Talk, like speak up, let's figure out what needs doing. So there's a lot.
Yeah, you touched on quite a few topics there, which are all relevant. The fee for service constraints of the profession. We don't have procedure codes or such to bill for our professional clinical time. We're still, anchored to a device-driven billing system, which historically has been around and will continue. I'm But in order to evolve as a profession, I believe we need to find ways to cope with that fee-for-service environment if we wish to evolve. It's constraining our evolution, but I think we have to just find more creative ways to deal with it in order to move forward. And I think to get at your other point about research endeavors, framing clinical questions that can be answered, which is kind of a research process. I think you're also seeing this shift where we're moving as an identity. We're moving from a technician device provision trade to a clinical profession, and we're struggling with it. We're making we have some hiccups along the way, but we're working on it. And I think that some of the solutions, I don't know if I have all the answers, but I think one of the ways to move forward is to reach out and to collaborate with other groups, other professions. And that's kind of what we are looking at doing at East Tennessee State. It's nothing new in medicine, but it's somewhat new in orthotics and prosthetics.
So there used to be pain clinics, okay, way back in the day, 70s and 80s, that were multimodal. They were like holistic, they were whatever, and like they had incredible outcomes, okay? And that know-how, that co-localization got snuffed out by fee for service, time, this, that, the other. And it's like, and people lapsed into, going to like a pill mill, right? So these things, so the World Health Organization, like, if you look back from there's a talk that I've given on interdisciplinary, basically coordination of care, right? It's like, it's been the mandate, it's been what should be happening during our training, even during our silo training. They want to expose medical residents to understand the professional role of a nurse, of a prosthetist, of a physical therapist, because there needs to be, you need to know how to interface, right? You need to know what they bring to bear. There needs to be mutual respect, but also a co-localization, cross-pollination of expertise, and joint decision-making, right? So we're not just serially in a silo. I make up my own treatment goals and you make up your own, and it's not patient-centered. Every time we do the patient-centered bit and we co-localize, patient outcomes improve dramatically, right? But here's the thing, how do we shore that up, right? When we're either competing with each other for profit or dwindling reimbursement, like those are the real constraints. So I can think of a role for myself, for instance, right? Like imagine a physiatrist who I'm not sitting, let's say at Vanderbilt, right, in my clinic. So let's say I can contract with, let's say, local providers, with Bulow, with Hanger, with Restorative Health Service, everybody in the area, right? And be like, I'm coming to you, right? 2 days out of the week, queue up, schedule who needs to be seen for supplies, new evaluation, whatever. Like, I'll contract with you, and guess what? I don't need to have a fixed place, right? I'm committed to going to Hanger for 3 days out of the week, whatever. So we have to be flexible in our planning, right? For people have a one-stop shop, right? They show up at their prosthetist, right? Patients are seeing under their roof, right? So the prosthetics, a prosthetic provider could basically say, you know what, I'm going to hire a couple of like physical therapists, set up a gym, right, that I'm going to give my patients free access to after they receive established care with me, right? And the physical therapists they're going to employ, they're like, you're going to give me a salary and I don't have to document? Woo, I'm there. I love it, right? We have to get flexible in our planning of how do we co-localize, how do we make it worth people's while, because that time spent, that face time, and that talking about the issues and nuancing each other's understanding, that's the magic sauce, right?
Yeah, I think trying to find that common ground that will be the bridge among the health professions. And
It's like we're taking care of people.
Right.
We're taking care of people. That's what it has to start and end with, right? So you're like, how people going to be best served, right? And we have, so I'll give you a very tangible, for instance, in my case, right? So once I established my outpatient practice, they're like, the hospital administrators expecting to have 15-minute visits, right? And I'm like, I'm a specialist. Like, there's no way I see somebody 6 months apart or 3 years apart, right? I'm going to take stock of the medical interval updates, get a sense of how they're doing, do a functional evaluation, a physical exam, and educate them in 15 minutes. So you know what's happening now? New patient visits, I have 2 hours with them.
Wow.
Okay. So, and it's been incremental, right? Because it's like, guess what? Yeah, because you're billing for time. It's not that, it's like I'm spending that amount of time with a patient. I can bill for that time, right? But the patient gets the benefit of a very thorough evaluation. We're sitting there talking through the stories. They take ownership. They understand it at their level, and they're like, and then they're good to go. It's like, yeah, we have to address motivation. We have to address like know-how. We have to address a lot of things, and they're serially staged because, like, let's talk about their weight, right? Let's talk about their pain. Let's talk about this, that, and the other, right? And the fact that sometimes you have to parry away, the fact that they're coming in with an ask because of the latest thing they saw in print, right? It's like
I think
not appropriate, etc. Right? So there's a lot that needs doing, and that can be done in a 15-minute chunk or a half an hour chunk, right? So in much like manner, right? So we got to figure out how to carve out what needs doing.
Yeah, I think in the profession of prosthetics and orthotics, for lack of a better way to simplify it, there's essentially two big boxes that represent challenges. One is clinical patient time, and the other is fabrication time.
Mm-hmm.
And out of those two boxes, we're only paid for one entity, is the fabrication and creation of the device. However, I think there is a possible, I wouldn't say a complete solution, but maybe a reduction of the problem of not being paid for clinical time, is if we as a profession, if we can find ways to improve our efficiencies of fabrication of the device at a cheaper, more, I would say not cheaper, but maybe more economical and more time efficient way, then in exchange for that, perhaps the clinician of the future could spend a little bit more time with the patient, the face-to-face time that you've described and that you've been having pretty good outcomes with. I think that might be one strategy to offer a way to cope with this dilemma.
For sure.
And then certainly the other that we've talked about is just spending more time with our referral sources and communicating and working together.
I'm always heartened. Like, I love how our local prosthetists and their staff step up, and here's the niche they have to fill inadvertently, right? So if Vanderbilt, let's say, doesn't have an interdisciplinary continuum of care, right, throughout, well, a patient care, basically coordinator, from one of the local prosthetic providers will have to come and educate, be the first face of contact post-operatively, right? So people are stepping up to fill that need, right? Because a floor nurse is not going to do it. The physical therapist is not well versed in it. A physiatrist may not be, there to consult, etc. So people have been very meaningfully, stepping up to do those things. Obviously, there's this sting of, well, I'm coming here, but I'm also coming under a corporate banner, right? And it's like, and people get lost in the shuffle, right? They're missing follow-up appointments with their surgeon, whatever. And sometimes the prosthetist will be like, calling up, hey, Mrs. Smith, don't forget you have an appointment. We'll also be at that appointment with you, right? They have taken it upon themselves, to fill up the gaps, the cracks, that healthcare systems have, right? But at the same time, they've also been seen suspect for doing it. Like, you're just trying to get the referral stream because it's a high-end billable device. It's like, you can kind of see it both ways, right? They're trying to fill an unmet need, right? Obviously, and trying to do the right thing by the patient, because the rest of the health system is not there doing what they're supposed to then free you up, to then, and But I will caution of one thing about, yes, efficiency, absolutely, offloading, division of labor, having, let's say, technicians who are not frontline, doing evaluations, intakes, castings, etc. Like if they're fabricating in the back, freeing up their professional assets for more face time and everything, assuming there's good rendering, good fabrication techniques and confidence and trust there. Let's not turn this into a rat race. Because if every time somebody says, oh, we'll improve efficiency, what I hear is burnout. Right? Nobody wants to get leaned on, right? Because like not everybody, it takes time to make one of these things right. And you can, I would much rather people actually keep falling in love with what they're doing, what they're there to do, right? And do it well, right? Obviously, yeah, no slouchers, no, but like that takes time. And I would much rather people measure twice and cut once, in a sense, right? Than just like render something and then get into a cycle of, now I got to see you back in 2 weeks. Now, what's wrong with this one? What's wrong with this one? And it's dispiriting, right? It's like, yeah, okay. And if you identify, right, like patients, even industry-wise, right, like you're like, okay, let me figure out my ship. Where are the leaks I got to plug up, right? So, and not in a punitive manner, right? If we can rise up to it, to be like, hey, I'm seeing a lot of return patients, for modifications, this, that, the other, with, pull assets aside and be like, okay, how can we help you? What feel comfortable with, this, that, the other, remedially, so to speak, right? It's like, it's like, yeah, you want to help people get better, right? And love what they're doing and not feel like they're leaned on and everything, right? But again, we're talking about, you're like, okay, that's just idealism. It's like, well, if we don't do those things or try to do those things, we know what we end up with. We know the devil we got right now, right? So it's like, we're trying to do a little bit better. And sure enough, it means changing what we're doing day to day a little bit and figuring out how to make that gain traction and become operationalized in perpetuity, right? But it's yeah, I mean, I think same as, it's not just a technical field, right? So OMP is aspirational, right? So, and this is the other thing that you're not prepared for, because our residents are not prepared for at all, right? So I gave a talk to our residents on coping, adjustment to disability, right? Like narrative repair, psychodynamic life narrative, of like take stock of what your patients, like they're there, you're tending to the medical piece and you don't go out of off the reservation, right? Because that's your comfort zone. But your patient's there to talk to you about their suffering, right? And unless you acknowledge it, this is a failed outcome, right? Management and treatment. And then what ends up happening is like PM&R has a higher burnout rate than internal medicine and other equivalent, time spent on the electronic medical record, whatever. We soak up people's grief, right? And we don't have any psychological training, right? Like for how to acknowledge, frame, discharge a lot of this, right? And it's the same thing with OMP providers, because you can get into, I can understand how somebody would be like, get caught into, I have to deliver efficiency-wise, fabrication-wise. I got to see these patients. I got to go to 3 different locations and 4 hospitals and 4 doctors' visits, clinics. It's like, that's a lot to put on someone, right? Oh, and my patients are like trying to tell me what's wrong with them, and I'm sort of tuning them out. That's a recipe for, it's not sustainable, right? And then they're going to look for the other job, right? Then they're going to look for this. They're going to look for that, right? It's there's a lot that needs doing for professional development. That's the other piece that we need to be speaking to our trainees about, right? Giving them a heads up about what the lay of the land is professionally, right? And in understanding what they're stepping into, enough to also do it aspirationally, know what to ask for, see the opportunities. You have to change the marketplace offerings, right? Because if you go in with an ask, you're like, look, I'd love to have, I'd love to be able to go off and workshop and, learn, pick up a technique a year. Like, are you going to sponsor me for that, right? Or I'm going to do this. I want to have 10% of my time protected for a pet research project that I have. Let me pitch it to you. Let me know if there's something there. We can potentially, collaborate with a local academic center. I've already contacted Dr. So-and-so, right? We want people to be like that, right? And unless we do, we keep on stumbling, right? And we can't let the payers dictate, right, the limits of what we do and how we do it and when we do it, right? The problem with that is we haven't taken the diligence, right, to shore up in the literature a body of work, like you're saying, that's not just underwhelming, right, for us to be like, no, 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 the minimum, the protecton for a pediatric patient is this many sockets, these therapy interventions, when this comes up, blah, 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 blah. This is the minimum you need to pour into this child to, safeguard their development, right? For somebody else, it's different. For somebody else, it's different. You're like, and qualifying those things and showing meaningful outcomes, which we also have to understand that prosthetic enablement outcomes are not functional outcome metrics, right? It's not the gait speed, right? Like it's not, it is, are you making it to work, right? Like, meaningful prosthesis utilization time during the day, donning and use time, right? It's like, it's other things, right? And there are patient-specific deltas, right? Because for my 80-year-old, transfemoral, patient, I don't have the same expectation. Like a new intervention has doubled what they can do, right? Which is meaningful to them and how they self-actualize, right? But I have a very different yardstick for somebody who is working at an Amazon warehouse and quite literally, they do like 30,000 steps a day, right? So it's like, okay.
Yeah. So kind of this, what the writing on the wall seems to be suggesting, at least in healthcare economics, is not only this fee for service, but with measured clinical outcomes, but this value, defining the value of the service. And I think that's going to be another horizon of interesting challenge for all the healthcare professions, including orthotics and prosthetics. And I think those types of challenges are all the more reason to collaborate and work as teams.
So yeah, I want to give you a couple of thoughts on that, okay? Because there are whole fields of medicine, right, that have a body of work and everything, because the metric that we needed to demonstrate outcomes on is very proximal. It's blood pressure. Let's say, here's the blood pressure, lower, done. Okay, 100% response rate, whatever. Enablement outcomes, right, rehab science outcomes are very different. Here's the problem. Somebody has already taken control of that conversation in the literature and talking to payers and saying, oh, we're going to set, yeah, of course we need standardizations and a yardstick. Here's your yardstick, time up and go test. You just shot yourself in the foot, right? It's like, so it's going to be done to us, but we haven't huddled as a field enough to say what are meaningful outcomes, and don't just reach for what was shelved in the literature 10, 15 years ago, because that ain't it, right? So putting patients through the combine, right? Like, through a gauntlet and saying, this is how they measure up. And it's like, okay, what are you using that yardstick for? Who qualifies for what? What's a meaningful outcome? But what are you using that for? Because it's useless, it's meaningless, right? So unless we huddle together and we're like, these are appropriate rehab outcomes, right? Which are not captured by single dimensional metrics, it's really difficult to say, what are we going to be tracking? So the people who are convening, right, the National Limb Loss Database, right? It's like, my estimation, very humbly, I'm like, be careful what you're tracking, because people are going to be like, is that what you want to track? Fine, we'll use that as a yardstick. It's like, and then we're going to find that's missing, lacking, wanting, and punishing, right? And it's like, be careful how you cue all this up.
Yeah.
And I don't think we're having that conversation, right? It's trickier. We don't even yet know how to train people to do rehab research, related research, right? So there's a whole other, like I said, methodology to it, and framing, right? Monitoring window, like statistical analysis, like framing questions, tracking, meaningful outcomes, and that we have to start doing that. We need to give that insight, right, to a whole new, generation of trainees just now coming out through their training, right? So that they know to aspirationally ask for it and work towards it. A lot of people, so many people, this is the other thing that's a little annoying, right? It's like everybody wants to chip in and help. Their heart's in the right place. If you're trying to do research without appropriate research training, right, it's hard, okay? Thinking's hard on all of us, right? It's like, but you end up, your effort might actually be deleterious to the collective whole, right? If it's not set up properly, looking at the wrong things, then arguing for the wrong things. So it's like, okay, And some of that is, unavoidable, obviously, but like, this is why we're going to stack, low level evidence, like haphazard case series, case studies, whatever, until we build up better, more credible, and those are the things we want to shelf, point to, and argue for. When somebody says, when we can march on Capitol Hill, right, and be like, we want this, they're like, I guess they want, what do you want, right? And then we're like, we want something done. They're like, okay, what do you want, right? So what are we asking for right now? We don't have it. Like, try arguing for a set price on a prosthetic. It's like, in the technology doubles the cost the next year. You're like, you did that to yourself, right? It's like, okay, so I don't know that we're all kind of huddling and having that, field-wide discussion somewhere, and enough to plan, right?
Yep,
So,
those are good points. Those are very well taken.
anyway, by the way, I really appreciate this. Very enjoyable. Happy to reach out. I'm at your disposal. Okay.
Great. Thanks, Dr. Bastas. I will reach out to you again to.
All right. Please. All right.
Enjoy.
Take care.
Okay. Bye-bye.
Right. And bye to everyone else also who stayed on here with us. Okay. So good.
Yes. Bye-bye, everybody.